A newborn baby who seems perfectly fine at birth, but weeks later, the baby is sweating profusely during feeds, breathing rapidly, and struggling to gain weight. Upon chest examination, placing a hand over the lower left sternal border reveals a palpable thrill, a distinct vibration beneath the fingers. Listening through the stethoscope, you hear a classic loud pansystolic murmur. What you are witnessing is a ventricular septal defect, or VSD. While small VSDs are often completely asymptomatic and picked up purely as an incidental murmur, larger defects present early with these classical signs of heart failure. What is VSD? VSD is the most common congenital heart lesion. It's an abnormal opening in the interventricular septum, which normally acts as a complete wall between the left and right ventricles. Anatomically, this septum has two main parts, a membranous part and a muscular part. While defects can occur anywhere, the vast majority of lesions are found in the membranous septum and rarely in the muscular portion. During systole, blood takes the path of least resistance, shunting straight from the high-pressure left ventricle across the defect into the low-pressure right ventricle. Blood doesn't accumulate inside the right ventricle. It streams directly out into the pulmonary artery. This dumps a massive surge of extra volume into the lungs, leading to interstitial fluid accumulation. All this excess fluid then returns from the lungs via the pulmonary veins, flooding into the left atrium and back into the left ventricle, eventually causing left ventricular dilatation. What happens if a large VSD goes untreated? Over time, the high volume flow damages the pulmonary arteries, triggering muscular hypertrophy and secondary pulmonary hypertension. As resistance in the lung vasculature skyrockets, the right ventricle has to pump harder, causing its pressure to rise. Once the right ventricular pressure exceeds the left ventricular pressure, the direction of the shunt flips. Deoxygenated blood is now forced from the right to left into systemic circulation, a life-threatening reversal known as Eisenmenger syndrome. Diagnostic findings vary based on the defect size. First, we do auscultation. Large ventricular septal defects may be present with a soft pansystolic murmur or sometimes no systolic murmur at all, alongside an apical mid-diastolic murmur from massive volume flowing across the mitral valve. A remarkable loud P2 heart sound signals underlying pulmonary hypertension. In contrast, a small VSD presents with a loud, harsh pansystolic murmur as high resistance across small defect creates severe turbulence. Second, ECG. ECG shows biventricular hypertrophy or left ventricular hypertrophy. Third, chest X-ray. Chest X-ray reveals cardiomegaly or left ventricular dilatation with prominent pulmonary vascular markings known as pulmonary plethora. And the gold standard, transthoracic echocardiogram. Transthoracic echocardiogram serves as the definitive tool to visualize the defect and confirm the shunt flow. Treatment. So the treatment depends on the severity. The majority of the small ventricular septal defects close on their own without an intervention. Moderate defects can often be repaired with device closure, while large defects require open heart surgery with direct suturing. Medical management with diuretics and ACE inhibitors help control heart failure symptoms. Now, if an infant is too small or unstable for a primary open heart repair, what do we do? In this case, a temporary procedure called pulmonary artery banding is performed. This will restrict the pulmonary blood flow and protects the lungs. If this helped making your studying easier, smash the subscribe button. Let me know what clinical topic we should conquer next, and I'll see you in the next video.